Hello, everyone, and welcome back to Karan Academy. My name is Karan. I hope you're all doing super well. For our 10th lecture for the series, we're going to be talking about infective endocarditis. So starting off, what is infective endocarditis? Well, as the name suggests, it's an infection of the endocardium, and the endocardium being the innermost lining of the heart walls. And it can also often include the valve leaflets and the chordae tendineae, which are the supporting tendon structures of the valves to prevent them from prolapsing. We'll talk a bit about the specific valves, but before we do that, I think it's good to talk about the risk factors for developing infective endocarditis. Predominantly, those include being of an older age, being of a male gender. A history of rheumatic heart disease is a very big risk factor because it predisposes you to having infective exacerbations. The reason of that being that with rheumatic heart disease, you often have microvascular and sometimes microscopic and sometimes macroscopic damage to the endocardium, and that can often precipitate further vegetative growth. Recent dental procedures are a big one, and IV drug use, as you know, is one of the biggest risk factors for infective endocarditis. And that's with any infection being immunocompromised is going to increase your baseline level of developing an infection. Now, infective endocarditis may be acute or subacute, and this often also depends on the organism. So acute infective endocarditis is one that usually develops days to weeks, is often more severe, and it's commonly caused by Staph aureus. Subacute infective endocarditis is often more sinister. It often takes longer to develop, and it's usually less virulent organisms like Staph viridans. However, the tricky part with subacute endocarditis is that it often may not be picked up quite easily because it may not present with as clear signs as acute infective endocarditis does. In saying that, you should always suspect infective endocarditis if you have a fever of unknown origin, especially with the development of a new heart murmur. And that is going to serve as our primary diagnostic basis. We'll talk about the exact criteria in a second, but I think we should talk about the complications of infective endocarditis itself. So embolic phenomenon is probably going to be our biggest fear when we talk about endocarditis. This is because in the primary mechanism of the infection is that of a vegetative growth, right? So as that grows, that not only does the growth itself have a risk of flicking off clots elsewhere, but also with turbulent blood flow, you're going to be at a high risk of generating new thrombi, and that puts you at risk of thromboembolic events. Now, unlike other cardiac pathologies like AFib that put you at risk for these events, this is going to be a bit more severe. As you know, our primary concern with AFib is that of stroke, because the parts that are contracting poorly are often the atria, specifically the left atrium, that is going to flick off clots to the brain. However, with infective endocarditis, because the vegetative growth is so widespread and it can be in any heart chamber, the parts of the body where these clots can go is going to be much more widespread. So this can be so you can flick off clots to the lungs, the kidneys, spleen, brain, skin, and retina. Some of these have a diagnostic purpose. For example, Osler's nodes, Janeway lesions, and splinter hemorrhages are all dermatological manifestations of infective endocarditis, which are all components of our cardiac exam. The big ones we worry about are brain, because it can cause embolic strokes or lead to the development of cerebral abscesses if you're flicking off vegetative growth. You can also have AKIs with renal infarcts and splenic infarcts as well. Rod spots are another big one and can often be picked up on an ophthalmological examination if done well. As you can see, there's some splinter hemorrhages right there. There's some rod spots which can be seen, and you can also develop cerebral abscesses, as we talked about. Some common causative organisms, the three main ones you should know would be Strep viridans, a common one for post-dental infective endocarditis, Staph aureus, the most common one by far, and big risk factor for IV drug use-induced infective endocarditis. And then you have Enterococcus. Some say that it is often post-colonoscopy, as you can imagine. You can also have some atypical bugs, and a good acronym for remembering that is the HACIC acronym. So Haemophilus, Actinobacter, Cardiobacterium, Echinella, and Kingella. So those 5, I guess it's good to have in the back of your mind as atypical bugs. Why is this important? It's important because when we talk about our antibiotic regimens, we can either have an empirical treatment or specific directed treatment. Our empirical treatments are going to depend on the person's valvular involvement and if they have had any procedures to a valve. However, ideally, we'd like to put them on targeted antibiotic therapy, and that's only going to be determined once you pick up what the exact bug is. That's important to know. To make a diagnosis of infective endocarditis, a certain criteria you need to be well familiar with is going to be the Duke's criteria. I would highly recommend learning this because this is something that does come up on exams quite commonly as well. To make a positive diagnosis, you need either 2 major criteria, 1 major and 3 minor, or 5 minor criteria. So our 2 major criteria include positive blood cultures, and these have to be from 2 separate sites, because at one site you can often have contamination. You also can, the other criteria being evidence of endocardial involvement by an echo. Now we can either go and perform a transthoracic or transesophageal echo. Both have been shown to have different efficacies for different valves, but overall you cannot rule out valvular involvement with just a transthoracic. You would have to do a transesophageal as well. Minor criteria include having a predisposition, so having a heart condition that puts you at a risk for developing vegetative growths, because you already might have some damage in the endocardium, or having someone who's an IV drug user. Microbiological evidence like a single blood culture, because if you have to, that's a major criteria. A fever greater than 38 degrees, and any vascular phenomenon. So the vascular phenomenon refer to the complications we talked about earlier. So any arterial emboli, mycotic aneurysms, septic pulmonary infarcts, conjunctival hemorrhages, Janeway lesions, all of those constitute a minor criteria as they're all vascular phenomenon. And then you can have echo findings consistent with endocarditis but not meet major criteria. So for it to meet the major criteria, you need to either have an endocardial vegetation, so a clear growth, an abscess. You need to have a new partial dehiscence of a prosthetic valve, so a part of the valve has degenerated, or a new valvular regurg. If you have something else on the echo that doesn't really meet this, then that constitutes a minor criteria. I don't think you need to know the specifics of what major involvement with an echo is, but just knowing that infective endocarditis specific stuff would be major. Anything that's still an echo change but doesn't meet any of this is going to be a minor. So going back, 2 major, 1 major, and 3 minor, or all 5 minor. In terms of treatment, so what we want to do is we want to manage the infection itself, obviously give some antibiotics, and then manage the embolic phenomenon as well. So in terms of antibiotics, a really good mnemonic that I've 2 good mnemonics I've learned are BFG and VFG. So the first thing we need to ask ourselves is, does the patient have native heart valves, or has the patient had an artificial heart valve? The reason there's a difference, so let's go through this. So if a person's had native heart valves, you give BFG, so benzyl penicillin, flucloxacillin, and gentamicin. As we know, benzyl penicillin is really good for gram-positive cover. Fluclox also really good gram-positive, but really good for Staph aureus in particular. Gentamicin is the king for gram-negative cover. If you look at the empirical antibiotics for an artificial heart valve, the one major thing that we change up is we switch them from benzyl penicillin to vancomycin. Now, why might that be the case? Well, that's the case because if someone has had a heart valve put in, especially if it's been in the past year, one particular organism that we worry a lot about is MRSA, right? So because they've been in hospital, it could have been a hospital-acquired infective endocarditis, and therefore they might be at much higher risk of MRSA, which is why you want to give them vancomycin. MRSA, for anyone who may not know, is methicillin-resistant Staph aureus. for which you would give vancomycin in particular. Other few important things to know is that if you do have valvular involvement with infective endocarditis, the order or the most commonly affected valves from the most to the least, in the order goes mitral, then aortic, then tricuspid, and then pulmonary. So those are the order. If you think about it, kind of makes sense. So the mitral is going to be the one that's receiving blood from a lot of your pulmonary circulation once it's been filtered through. Your tricuspid is going to be the most affected valve if the cause is IV drug use, right? So if you don't want infective endocarditis, don't try drugs, and the try in that refers to the tricuspid valve, because IV drug use is going to lead to tricuspid valvular involvement with infective endocarditis. The reason for that being is if you obviously inject and you have the introduction of new bacteria, the first heart valve that it's going to reach as it enters the heart is going to be the tricuspid, which is why it's going to be at a higher risk. The reason the mitral is often at a higher risk as well is because with rheumatic heart disease, the most commonly affected valve with rheumatic heart disease is going to be the mitral. So if you have some levels of background damage to the mitral valve, that can often cause irregularities on the surface of the valve itself, and therefore lead to higher risks of there being vegetative growth developing on it. Once you develop vegetative growth on the mitral, the next site it's going to go to is going to be the aortic, right? And then your tricuspid, and then your pulmonary. I hope that made sense. If you have any questions, feel free to get in touch with me on my email or through Facebook. And as always, please look after yourself and please look after your loved ones.